Hello, my name is Joe Pachunka. I'm a third-year MedPeds resident from UNMC, here to present Doxy alone can't fix this. Along with Dr. Mark Ritter and Dr. Richard Hankins from the Department of Internal Medicine and the Department of Infectious Disease, we have no financial disclosures. Our case begins with our patient, a 41-year-old gentleman presenting with 5 days of worsening fever, body aches, sore throat, shortness of breath, and a productive cough with associated pleuritic pain. Vitals were significant for hypotension and tachycardia. On exam, he had increased work of breathing and diminished lung sounds in the right lung field. He did not have a leukocytosis, but procalcitonin was elevated to 9.46. He had a chest x-ray demonstrating a 5 centimeter right upper lobe cavitary lesion that we will review in Figure 1 on the next slide. He was negative for COVID, and medical history was significant for asthma. He had a history of gastric bypass, and he had been on PrEP with recent negative HIV testing. He had an extensive infectious disease workup after admission that was unrevealing. At the time of admission, he was empirically treated for sepsis with vancomycin and cefepime, and later transitioned to ceftriaxone and metronidazole following clinical improvement. He was discharged home on IV antibiotic therapy, with the plan being to continue therapy for at least 4 weeks. Here in Figure 1A, we can see the 5.2 centimeter right upper lobe cavitary lesion, the left lower lobe consolidations obscuring the heart border, and a small left pleural effusion. The recommended follow-up CT is in Figure 1B below. You can see the cross-section of the right upper lobe cavitary lesion and the left pleural effusion also present. The read also commented that the cavitary lesion had a mass-like quality. There was other areas of consolidation, especially in the left lower lobe, not shown here. Unfortunately, our patient was in the infusion center 9 days from his initial presentation, receiving his IV antibiotic therapy when it was noted that he was hypotensive with a systolic blood pressure just above 90 and a new leukocytosis noted in the clinic the day prior. Although he was asymptomatic, he was sent to the ED for further evaluation. He was found to have diminished breath sounds throughout the left lung field and a chest x-ray, which will be shown in the subsequent slide, significant for hydropneumothorax with signs of tension, including a mediastinal shift. A chest tube was placed, which facilitated the drainage of the empyema and 2 liters of purulent fluid. During this hospitalization, he was again covered empirically for sepsis, and antibiotic coverage was later narrowed following clinical improvement and a negative infectious workup. It was not until 5 days after chest tube placement that Mycoplasma hominis was isolated from the bacterial fluid cultures, at which time doxycycline was added to his antibiotic regimen. With lack of clinical improvement and concerning findings on imaging, he was taken to the OR for VATS and surgical debridement. He was taken back on 2 more occasions for debridement, with the last procedure being relatively minor. He was subsequently discharged home on a 6-week course of oral levofloxacin and metronidazole, with M. hominis susceptibility testing still pending at an outside lab. Now let's finally look at the imaging obtained at the time of readmission here in Figure 2. In A, you can see the initial chest x-ray demonstrating the hydropneumothorax, complete with signs of tension, including mediastinal shift to the right. You can also appreciate the 2 liters of soon-to-be-drained fluid filling the left chest cavity and air in the apices. You can also see the right upper lobe cavitary lesion here again. In B, we can see our chest tube with resolution of tension, but with opacities throughout the left lung field and extensive subcutaneous emphysema. In C, the CT demonstrates evolution of the right upper lobe cavitary lesion and significant consolidation throughout the left lower lung. Here you can also better visualize the extensive subcutaneous emphysema and mediastinal gas. Now let's take a step back to discuss the learning objectives drawn from this case. First, we're going to review considerations for cavitary lesions, and then second, we'll review Mycoplasma hominis biology and its role in human disease. When first encountering a cavitary pneumonia, one of the biggest things that can help us to distinguish between various etiologies would be the progression of symptoms or the time course. Although our patient's initial presentation could be consistent with bacterial pneumonia or bacterial cavitary pneumonia, it should raise concerns for atypical infection, fungal infection, or malignant etiology. Our radiology colleagues raised those considerations for the differential even on the first initial imaging studies. For the acute presenting bacterial pneumonia, the most common culprits would be strep species and Klebsiella. You should also consider staph and pseudomodal coverage based on your patient's individual risk factors and depending on your clinical concerns. Among Mycoplasma species, we are much more familiar with Mycoplasma pneumoniae as an etiology of atypical pneumonia, but other Mycoplasma species are uncommon etiologies of human disease. Mycoplasma are unique in their small size and lack of cell wall. Their lack of cell wall naturally makes them resistant to antibiotics that use that as the mechanism of action. Specifically, they are resistant to all antibiotics that target peptidoglycan synthesis, which includes all beta-lactams and cephalosporins. M. hominis is susceptible to tetracyclines, fluoroquinolones, and is sometimes treated with macrolides. There were only a few cases of immunocompetent patients with respiratory infections due to M. hominis, but more in immunocompromised and transplant patients. There were also case reports of other types of infections, which can often be quite severe. A theme running through all of these case reports is a poor outcome if there is not a timely identification and switch to appropriate antibiotic therapy. This would be the point I'd want to stress, that if you have failure to improve, consider a tetracycline or fluoroquinolone to cover these types of rare infections or other atypical infectious etiologies. You can see a list of my references here. We will conclude the presentation with my poster, which, pre-COVID, you would have been able to visualize on an easel in all of its 2 by 3 foot glory. Then finally, before this presentation completely comes to a close, I would like to take the last few moments of this presentation to acknowledge my co-authors, Dr. Mark Ritter and Dr. Richard Hankins, for their assistance putting this together. I would also like to thank the MedPeds Residency Program and the Internal Medicine Residency Program, along with the Departments of Internal Medicine and Infectious Disease. And of course, I would like to thank the ACP and to all of you for listening. And if you have any questions, I'd be happy to take them at this time.